The broadcast is now starting. All attendees are in listen-only mode.
Well, good evening, future doctors. I'm Jeff Downing, and welcome to tonight's RX Question Lab, where we're going to be diving deep into one of the most fascinating and clinically critical systems, cardiovascular system. Tonight we're tackling cardio, and this represents about 15 to 20% of step one questions, and obviously these are kind of represent some of the more elegant pathophysiology that you're going to encounter in medicine. So we're going to work through some challenging scenarios that test everything from cardiac conduction abnormalities to inflammatory conditions, hemodynamic assessment, cardiovascular pharmacology. And, we go into this knowing that, understanding how the heart works is pretty fundamental to keeping your patients alive. So as future physicians prepping for step one, it's not just about memorization. It's about, really learning to think systematically about cardiac function and recognizing these presentations and understanding, the underlying patho. So we are so glad that you're here tonight. And I am thrilled to be joined once again by Dr. Abraham Titus. Abraham, would you like to introduce yourself to the crowd?
Thank you, Jeff. Well, it's a pleasure to be here and talk about some high yield cardio with you guys. I gathered some questions that I think would be great to hit, some big points to cover. I've been a tutor or / coach with RX for quite a few years now, and continue to do so throughout my residency and my fellowship. And it's been great to work with students and kind of see them as their metaphorical light comes on and they get comfortable with answering questions. And that's what we're going to go over today, about how to tackle questions, how to have the correct strategies, and how to make sure we're more efficient with our time. Looking forward to it.
Okay, so thank you, Abraham. Yeah, so the answer choices are covered up, and basically we ask students to do that first, just so, again, we want you to be focused. And if you see an answer choice, a distractor that you don't understand very well, or that has tripped you up in the past, sometimes that can be distracting. Sometimes that can lead you astray. So what we want you to do is cover up the answer choices, and then we want you to read the lead-in first. And the lead-in is the actual question. So in this case, the lead-in is, which of the following abnormalities is most likely in this patient? So you might say, Jeff, well, I've got the scenario up there. Why not read that first? Why not just read that vignette, understand what's going on? Part of the method here is, if you read the question first, it will kind of provide a pathway, a guide to the scenario, so that you know what it is you're looking for, things that you may want to focus on, especially if you know what type of of information or what type of data might help you answer that question. We also advise you to do it because every now and then you're going to run across a question that you might be able to answer without even reading the vignette. That's very rare, especially on step 1 or step 2 CK these days, but it does happen. Regardless, we say read the lead in first, and then we read the vignette. Okay, so kind of knowing that we're expecting some abnormalities that we're gonna be trying to identify, let's go ahead and read the vignette. A 32-year-old man comes to the clinic because of recurrent episodes of dizziness, during which his heart beats rapidly for several minutes, and then he loses consciousness. An ECG taken while he's asymptomatic shows a PR interval of 80 milliseconds. An ECG taken during an episode of dizziness shows a wide complex tachycardia at a rate of 180 per minute. So again, the question, which of the following abnormalities is most likely in this patient? Think to yourself of what abnormality you might expect to see without even seeing answer choices, while I pass it over to Abraham.
All right, thank you, Jeff. So, we're doing cardiology, so we have to deal with some EKGs / ECGs. and some arrhythmia questions. Okay, so this is a kind of a classic situation. You're going to get situations similar to this, and I want to make sure you guys get exposed to this early and can get recognized this. So let's go through, let's highlight some keywords of what's most important from this question, and let's kind of go over it one more time. So, 32-year-old man, especially in cardiology, it's important to know, am I dealing with a 70-year-old, 80-year-old versus a younger 20, 30-year-old? Recurrent episodes of dizziness. Okay, so he's been having something that's making him dizzy all the time. Now, on the actual exam, you're not going to be like, oh, this is a cardiology right away. Dizziness can mean many things. So you have to make sure you keep your differentials wide. But as you start reading more, oh, his heart beats loudly. Okay, he's losing consciousness. And then they talk about EKGs. When he's asymptomatic, his PR interval is 80 milliseconds. So what is a PR? It is a high, low, normal. And EKG during these dizzy episodes was wide complex tachycardia. Okay, and the rate is 180. So it's definitely a high rate. We never want our complex to be wide. Okay, so when it starts widening, it's kind of a dangerous thing that's happening. So there's a few alarm symptoms here going on, but also some classic symptoms or things that are going on in this patient. Now, you may already know what's going on. You may already think, okay, this is for sure what this patient has, what this thing has. But the question is asking about abnormalities, right? That's why we lead in first. You want to make sure it's not just asking what's the diagnosis, it's saying what's the abnormality. So you want to think about the pathophysiology behind the diagnosis. So take a second, process all of this as we pull up the options and go through them. All right, so we got 5 really good options here. As we can see, they're all kind of cardiology related. We want to make sure which is the one that's associated with this syndrome. I like to start with E and make my way to the top, just because I always find that if there's a distractor they're trying to put, they usually put it at A, and I want to try to avoid that. We'll start with E, inherited myocyte ion channel defect. Option choice D, increased sympathetic tone. Option choice C, increased conduction across the atrioventricular node. B, delay of conduction across the atrioventricular node. Option choice A, propagating signal using an abnormal conduction pathway. Again, all this stuff, some signal problem, some type of channel defect, all these have got to do with something that's causing the arrhythmia, okay? Something that's causing this patient to have these presentations. Take your time, think of step 1 as a diagnosis, and then step 2 of what's going on and that's causing the diagnosis. All right. And Jeff pulls up the poll right here. You guys take your time, think about the patient, the dizzy spells, think about what's happening in the EKG, and take your time and pick the answer that you believe is the most correct.
Very good. Thank you, Abraham. So go ahead and give it a shot. What do you think is most likely in this patient? And let's share the results. Okay, so 41% of you went with answer choice A, a propagating signal using an abnormal conduction path. Almost a third of you went with answer choice B, and almost a fifth of you went with answer choice C. So, okay, interesting mix. Got, 2 pretty big vote getters. So I'm going to go ahead and hide the results, and let's share the answer. And the answer is answer choice A, a propagating signal using an abnormal conduction pathway. Great job, everybody. That's a good way to start off our cardio question lab. I'm glad to see so many were able to pick that one up. If you didn't get it right, though, hey, that's why we're here. So Abraham is going to walk us through the explanation.
Great job, guys. And just like Jeff said, if you didn't get that right, don't feel bad. This is a tricky question, but it is one that's very high yield, and you're going to see multiple times as you study for your step. So can anyone think of what condition or syndrome I'm talking about in this situation? Right, you have an abnormal conduction pathway. Right, this is the world-renowned, I guess, Wolff-Parkinson-White syndrome. Okay, so this is the one that we always see, WPW, and we see that thrown around all the time. So what essentially is that? So that you have to kind of understand the actual condition, not just memorize it and know, oh, this is what the buzzwords are. You want to know what's going on. So whenever I see a young person with these kind of recurrent episodes of like passing out, not explaining what's going on, you always want to keep that in your differentials. On an EKG, we would typically see what's called the delta wave, right? Where you see that slurring or that slow upstroke of the QRS before the rapid upstroke. And if you kind of look up what a delta wave looks like, you kind of get used to seeing it. That'll be the way. But in this question, they don't give that to you, right? That's the trap. So they're not giving you an EKG from a delta wave. Instead, they're explaining it in a little bit. So when he's at rest, asymptomatic, his PR is 80, which is actually short. Okay, typically you should expect around 120. So it's a shorter PR interval. So that means that his QRS is widening and his PR is shortening. That's kind of a classic picture here. So when they have that combination of QRS widening with the PR getting shorter, and typically with a delta wave association, you want to think about Wolff-Parkinson-White. And in this situation, when you start seeing the classic presentation of a young male or female passing out without any clear explanation. Let's look through the options and let's try to figure out why it's not the other ones, right? Because some of these other ones can also cause passing out spells. What if it was an inherited ion channel? That would be the long QT syndrome, right? That's associated with a sudden death in young patients, but you wouldn't get that PR interval shortening. And it would typically kind of talk about some family history of people passing out and passing away like that. So it's not the typical presentation, and they wouldn't give this to you like this. Option choice D, increase sympathetic tone. So again, when you increase my sympathetic tone, my heart rate is going to go up, my blood pressure is going to go up. It's not really going to affect PR or cause syncopal episodes. So that doesn't really fit with what's going on. What about the conduction? Right, so you have increased conduction and decreased delay of conduction. This is kind of the trap where a lot of people get caught in this trap because you're thinking about, okay, what's going on, right? When I have Wolff-Parkinson-White, I have a bypass. So the signal normally travels from SA node to AV node to my Purkinje's. If I have a bypass that bypasses my AV node, then that's how this presents. So again, increased conduction across AV node is wrong because you would have decreased conduction across AV node because there's a bypass that gets around the AV node and that can trigger this. And the delay of conduction, it's not a delay because the delay, we're talking about heart blocks, is just a reduced conduction. So it's the wording that's important here. It's not a delay, it's not increased, it's decreased conduction. And because it's bypassing the AV node and having its own conduction pathway, we call it the bundle of Kent. So very high yield, lots of little nuggets in this question here. They can ask you different ways to ask this question, and they can kind of make any of these options the correct answer if they just change up the vignette. So you want to be familiar with every single thing I talked about. But great job, guys.
Yep, good way to get this Q Lab started. So again, this is all about helping you so that you're ready on test day. So never get discouraged. We're moving to question number 2. And once again, we've got those answer choices covered up. A little bit of a denser vignette. So it's important to see what it is we're going to be looking for. So let's read that lead in. Which of the following is the most likely cause of this patient's condition? Okay, so here we go. We're going to, we know this is going to be a 2-stepper, right? We're going to have to figure out what's wrong with this patient and then, what caused it. So with that, let's read the vignette. A 65-year-old man comes to the clinic because of 1 day of chest pain at rest and subjective fevers. The pain is most severe when he is supine and better when he leans forward. He has a history of myocardial infarction 2 years ago, treated with angioplasty. This is the first time he has experienced chest pain since his MI. 6 days ago, he had a flu-like illness with cough, fever, and fatigue, now resolved. Medications include atorvastatin and metoprolol. Blood pressure is 126/84. Physical exam reveals a faint rubbing noise over the left side of the chest. ECG shows Q waves in leads V3 through V6 and ST segment elevations in all leads. X-ray of the chest shows no acute cardiopulmonary process. So again, the question, which of the following is the most likely cause of this patient's condition? Think through this one as I pass it over to Abraham.
All right, so a little beefier question here, and there are some very high yield things to highlight in this vignette here. So again, most likely cause of patient condition, right? We're thinking again, more than one step here, not just diagnosis. Think about what's the cause or underlying reason why the patient is presenting this way. So let's go through, highlight some keywords here, and not waste too much time with all the little details. Make sure, when you see big vignettes like this, you want to make sure you catch out for key buzzwords and really understand the story they're trying to paint here and not get caught in the weeds. Okay, there are going to be questions on step one that are like 2 paragraphs long sometimes, and you have to make sure you just don't lose yourself in the question. Don't start zoning out. Okay, all right, so we have a 65-year-old man, a J of chest pain, subjective fevers. Okay, so chest pain, big differentials, right? You want to think about all the things that can cause chest pain. It's severe with supine, better with leaning forward. That's unique. He has a history of MIs. That's important to understand. And he had an angioplasty about 2 years ago. Okay. 6 days ago, he had a flu-like illness. Okay. And he's currently on what you expect for somebody who had an MI, right? Metoprolol and torvastatin. Then the physical exam, right? Always pay attention to physical exam. Step loves to give you clues on this. Faint rubbing noise on the chest. And EKG shows Q waves in V3 to V6 and ST segment elevations in all the leads. That's interesting. And X-ray is fine. So they're giving you typical presentation of this one condition, and then they're asking you, why did they get this condition? So that's the 2 steps you need to think about. Look at the buzzwords that are highlighted, look at the story overall, and try to understand what is the reason why this patient is having this chest pain. And then let's use that to guide us to get to the cause. Okay, so let's pull up the options here. Now, we're going to go through from E to A again. Option E, viral infection. Option choice D, pulmonary infarction. Option choice C, pleural inflammation. Option choice B, myocardial ischemia. Option choice A, autoantibodies. Again, good options here, and many of these can cause whatever chest pain situation can happen. But in this particular situation, what would be the most likely cause of the patient's chest pain? Take your time, go through the vignette one more time quickly, but really focus in on what the diagnosis is. And then once you know the diagnosis, and once you know the story, then use that to guide what's the cause.
Okay, everybody take it in. I'm about to launch the poll. Almost half of you went with viral infection, and about a third of you went with pleural inflammation. So kind of a bit of a mirror of the first question in terms of answer choice breakdown, but 75% of you went with one of 2 choices. So that's indicative of something. So let's go ahead and hide the results and see what the answer is. And the answer is indeed answer choice E, viral infection. So once again, a lot of you got that one right, which is great. It means that you're able to kind of do the old 2-step here, right? You're able to kind of figure out what was going wrong with that patient and and what was causing that. So great job. But if you didn't get it, that's okay too. We're gonna help you figure out how to get it right the next time. Abraham?
All right, well, great job, guys. Okay, so again, this is another beefy high yield question. I saw a lot of you guys in the question box saying the diagnosis, which is correct. This is pericarditis, okay? So this is a situation when you see chest pain, you don't want you to always think, oh, this is an MI every single time, right? This could be pneumonia, this could be PE. You have a very broad differential when it comes to chest pain. So you want to look at the rest of the story. Okay, he's had chest pain for a day. It's at rest, and associated with some subjective fever, some chill, so maybe some infectious-like picture going on there. Now, this classic presentation of better with leaning forward and worse when supine or with inspiration is classic for what we call pleuritic chest pain or chest pain that's seen in pericarditis. Now, he had a history of MI 2 years ago, so that's important to understand because, if it was last week, that's a different story. 2 years ago, it's been in long enough where that post-MI pericarditis is much lower likely in the situation, right? So option choice B with the myocardial ischemia, that you would expect if this guy had an MI, let's say, and then like 4 days or 5 days later, he comes in with this kind of presentation. That's that typical, post-infarction fibrinous pericarditis, which is not what's going on here. They do give you a week ago, he had a flu-like illness. Okay, that, a viral infection leading to pericarditis is a classic presentation that can always present. So you always want to be aware whenever they drop random things like, oh, he was sick recently. You don't know what bug it could be. And which bug do we know that causes pericarditis? Coxsackie B. That's a high yield micro question right there. Other key things, physical exam, like I said, faint rubbing noise. That is my friction rub. That's the sound of the heart rubbing against the lung when the patient breathes. And then the EKG findings are very high yield as well, right? So the Q waves are just showing prior MI, right? I saw somebody put that in the question bank as well. Yes, V3 to V6, Q waves means that, oh, he had a previous injury to that area. Q waves typically indicate prior injury. So he had a history 2 years ago. This kind of fits with that. Whereas he has ST elevations at all the leads. Now, we always associate ST segment elevation with MIs, right? But that's not always the case. When I see an ST segment elevation, it's got to be in contiguous leads. For example, 2-3 AVF is my inferior leads, my V3, V4, V5, like there are specific leads that are associated with different parts of the heart. In this situation, in all your leads, you wouldn't expect the whole heart to have an MI. So that just indicates that the whole heart is inflamed, and that's pericarditis. So diffuse ST segment elevation, friction rub, and the classic, chest pain with leaning back and with taking a deep breath. That's the classic presentation. Looking at the other options, autoantibodies, they're trying to get at, lupus associated or Dressler syndrome, things like that. Not really giving you that picture here. This is a 40-year-old female with lupus, then you would pick it. This is option choice B. Again, we talked about that already. Option choice C, pleural inflammation. That'd be like pleuritis, which can also happen with lupus and associated maybe with pneumonias. Not really what's going on here. Pulmonary infarction, not really what's going on here as well. If there was actually a pulmonary infarction, you would probably see that on the chest X-ray as well. And a lot of people ask me what the cardiopulmonary process meant. That's something that radiologists will typically throw on an X-ray when they say, hey, there's nothing obvious that we can see on X-ray, right? This is something that's happening in the pericardium. It's much more small, where an X-ray is going to just show you a big pneumonia glaring at you, or if you have heart failure, congestive heart failure with the lungs full of fluid. It's not going to show you some minute changes in the pericardium, or if I have a PE, for example, it's not going to show up on X-ray. So those are some important things to be aware of. And in this situation, that's kind of what they're really trying to get at here. But great job, guys.
Okay, you guys doing really well so far. We're about halfway through, and it is time for our stretch break. What I'm going to do tonight, I'm actually going to do a really quick poll. I kind of want to see how many RX subscribers are here in the audience. So let us know which RX product you're using, or if you're still kind of thinking about it. For us, just looking at the cardiovascular topic tonight, we've got a lot of things that are designed to help students build their cardiovascular knowledge. Our QBank has, I'm not quite sure how many. We've got a few hundred cardiac specific questions that mirror what you're going to see on step 1. Also, similar for step 2, we've got bricks that break down complex topics like cardiac conduction pathways and pericardial diseases, express videos that provide visual explanations, like ECG interpretation, cardiac cycle mechanics, and all from students who have been in your shoes and understand, hey, what are the things you need to know? What are the things that are testable? Obviously, we've got our flash facts and study stream for those quick sessions. So, we've got a lot of things that are designed to help you here. So I'm going to close the poll, and let's see, we've got quite a few 360 users out there. We've got some QMAX users, some flash facts and express videos folks, some people that are going through the trial, and some that are just interested. So that's great. Well, we're excited to share more about what we're doing here at RX, and obviously the question lab is just one of the things that we do to help students from around the world get ready for game day, right? Get ready for for those key assessments and for the boards, as well as to help you succeed in med school. So we're going to have a special offer here at the end of tonight's session. So for those that are thinking about it, we'll make it a little more attractive. Okay, with that, I am going to move us into the second half of tonight's workshop, and we are ready for question 3. So again, we've got the answer choices covered up. We're talking about ECG. So the lead-in of the question is, which of the following is the most specific ECG finding for the disorder most likely causing this patient's low blood pressure? Okay, so again, multi-step question here. We've got, you already know that the patient has low blood pressure, and you're going to have to figure out, what's the disorder that is resulting in that, and then figure out the ECG finding that helps reveal that. Okay, so there's a lot here, and that's this is a good reason why you want to read that lead in first, because that lead in is a mouthful, right? So most likely it would force you to go right back into the vignette and start carving it up. So with that as our compass, let's go ahead and read the vignette. A 75-year-old woman with advanced esophageal cancer comes to the emergency department reporting several days of dyspnea and chest pain. Blood pressure is 80/39. While measuring the patient's blood pressure, a practitioner finds that Korotkoff sounds are heard only during the expiratory phase. After a drop of 15, the Korotkoff sounds are heard throughout both the expiratory and inspiratory phases. Physical exam reveals the jugular venous pressure is 14 centimeters H2O. So once again, which of the following is the most specific ECG finding for the disorder most likely causing this patient's low blood pressure? And I'm sure some of you may be thinking about that disorder. You can go down and let us know in the question box as I pass it over to Abraham.
All right. Well, we're doing cardiology, so you're going to see quite a few ECG questions. But this is a little bit different. We have someone who's a little sicker, actually, So we want to make sure we understand the story here. We understand what finding we're going to expect to see on ECG. And I like this question because it's a very classic topic, but also it's phrased in a way where most people may not catch what they're talking about right away. And STEP loves to do that, right? Because cardiology is something that they expect everyone to study hard. So they'll ask you detailed questions, and they'll just mix up the wording and the phrasing of it sometimes, and know that, oh, I didn't just memorize a buzzword. I understand the concept really well. So let's talk about this. Let's go through this. Let's highlight some keywords, and hopefully you guys are able to understand this one. So again, most specific EKG finding of a disorder, okay? Specific, okay? You can see multiple EKG findings, but the one that's going to be the diagnostic one for this. 75-year-old woman with esophageal cancer, okay. Dyspnea, chest pain, low blood pressure, and then, we hear these Korotkoff sounds, right? What is Korotkoff sounds? Only during the expiratory phase. And then when the blood pressure drops 15, then you hear it both in the expiratory and inspiratory phase. It's like a weird kind of explanation. What does that mean? Try to make sense of it. If not, we're going to talk about it soon, okay? Just try to see what they mean when they explain that. And then the physical exam, always pay attention to that. You have JVP of 14, which is high. So you have a few classic features here, but I don't want to give away too much, but I want you guys to think about what's going on. Use the clinical judgment to kind of understand, okay, how sick is this patient? What are the risk factors in this patient? And what is going on that's making her present like this? And then once I get a diagnosis, then I can go, what's the most specific EKG finding that I can see in this patient? So take your time, process all of this as we pull the options up here. All right, so option choice E, QT prolongation. Option choice D, peaked T waves. Choice C, prolonged PR or PR prolongation. Option choice B, diffuse C segment elevation. Option choice A, alternation of QRS height with each beat. Now, each of these are high yield in its own way, and you kind of want to be familiar with each of these, what these letters mean. They're not just alphabets, right? Each of them represents something that's happening in the heart. And we can talk about that when we talk about the explanation. So I want you guys to take a second, process what's going on, and which EKG finding is specific to the one that's causing the features of the blood heart. Thank you. We'll wrap see what's going on with this one.
Okay. Well, I'll tell you what we're going to do is we're going to launch the poll, and you can let us know which of these options is the most specific ECG finding for the disorder that this 75-year-old woman appears to have. Looks like like we said, the long question, I think we hit the character limit within quick poll, so. Okay, a little more of a spread this time. About almost half of you went with alternations of QRS height with each beat. PR prolongation came in second with about 21% of the vote. Diffuse ST segment elevation with about 15%, and QT prolongation at 11%. So, okay, well, good, interesting mix here. So I think folks were looking at this and seeing some plausible options. So what I'm going to do is hide the results, and let's reveal the answer. And the answer is answer choice A, alternations of QRS height with each beat. So nice work, everybody. That's, so far it's pretty strong. Again, these are some tough questions, and if you didn't get it right, that's okay. The main thing is, are you walking away from the question with a better understanding of, what was tricky here? And that's why Abraham's here, to help clear things up. Abraham, take it away.
Great job, guys. And I see that a lot of you guys mentioned the correct diagnosis in the question box. This is indeed cardiac tamponade, right? This is our classic presentation of tamponade. And, the option choice A is the correct answer. It's okay if you guys didn't get that right. Let's go through and kind of break down what each of this thing is. Because it's not a huge vignette, but there's some very high yield points they can explain. Okay. The fact, first of all, the fact that she has esophageal cancer is important, right? That is something that can trigger pericardial effusion, which can lead to tamponade. Trauma, post-MIs. Our previous question, right? He had a viral infection leading to pericarditis. That can lead to pericardial effusion and tamponade, right? There's many, many causes of tamponade, but you want to be able to be familiar. Trauma to the chest, surgery, cancer by itself can cause it, especially anything in the chest. So lung cancer, esophageal cancer, lymphoma, things like that that can just cause like fluid buildup around the heart, can lead to tamponade. The way I think about tamponade is this, right? So we have a heart and it's pumping in our chest. Now, let's say our heart is surrounded by a bag, and that's the pericardium. Now, normally our heart is in one place in our chest pumping. It's pumping away, pumping blood to the rest of our body. Now, when the pericardium is filled with fluid, our heart just starts swinging around in the chest, right? If you think about it, if you have a pool and I put a floaty in the pool, is it going to stay in one place and move around? It's moving around, right? There's fluid inside the pericardium. It's a bag full of fluid, and the heart is just swinging around in there. It's not staying in one place like me and you. That's kind of the explanation here. Okay, so let's use the buzzwords here, and that swinging of the heart is what creates the alternation of the QRS heights. As the heart swings closer to the leads, the QRS looks nice and tall, and it swings away from the leads, you have small baby QRSs. And that alternation is called electrical alternans and is a pathognomonic or specific finding we would see in tamponade. What are some of the other findings we see in tamponade? So we have hypotension and JVD, which she both has, or she has hypotension, 80/30, and then jugular venous distension with the elevated jugular venous pressure, right? And then technically you'll have the muffled heart sounds, which they're not giving that to you because that makes it too obvious that it's tamponade. So this is a typical, they'll give you either hypotension and JVD plus one of the extra bonus findings, right? They'll either give you electrical alternans or they'll give you this thing that they're explaining in the physical exam. This is called pulsus paradoxus. I'm sure if you guys have heard these buzzwords thrown around, you need to understand what they mean by pulsus paradoxus. Pulsus paradoxus is when I have inspiration, my systolic blood pressure drops by 10. Now, at least 10 or greater. Now, that's clinically hard to grasp, right? We're not actually going to be taking their blood pressure and asking the patient to take a deep breath and watch the blood pressure drop. Typically, that's not how we would see that, but it's a clinical situation. This patient's actually dying. We have to do something fast. One classic way is you feel the patient's pulse. And when the patient takes a deep breath, when their systolic blood pressure drops, it gets closer to their diastolic, so their pulse pressure disappears. So it's a loss of pulse during inspiration. That's why they call it pulsus paradoxus. So tamponade, the Beck's triad is hypotension, JVD, muffled heart sounds, and the two bonus findings you're going to see is electrical alternans in the EKG and pulsus paradoxus on physical exam. Other options here, quickly going through them. Diffuse SI segment elevation was the last question. That's pericarditis. So that would be more chest pain without having these hypotension and all these other features. So you just have the the classic features we talked about last time with the friction rub and things like that. PR prolongation. Okay, what is PR prolongation? So we can see that if someone is taking, has an AV heart block, or if they're taking lots of beta blockers or calcium channel blockers, right? It's essentially when the AV node is blocking, then the PR prolongs. Peak T waves, that's hyperkalemia, right? So we can see that in hyperkalemia or in an early MI. When I first have an MI, I can see peak T waves as well. And then QT prolongation, we talked about that. There's the long QT syndromes, all the drugs that can cause prolongation of QTC. They love to test that one. You need to know. Or idiopathic, we don't know why they can happen as well. So that's very important to understand. But in this question here, understanding this patient's in tamponade is the first step. And tamponade, guaranteed you're going to get at least one, if not more, questions on the exam. Good job, guys.
Okay, everybody. Well, a great one, and honestly, there was a lot of value in that explanation, right? Because again, all of these questions, could be altered. Just a couple of a different finding here, or a different presentation there, and one of the other answer choices might be right. So you can when you're reviewing a test in QMax or UWorld or whatever you're using, it's always it's a nice challenge to kind of look at the questions and then think to yourself, okay, well, in what case would answer choice C be right, or D? So there's a lot in here. So I always appreciate it when Abraham can show just all the different steps that might be helpful come test day. Okay, with that, we are at the end here. We are at question number 4, final question of the night. I know we've a little bit behind schedule here, so just a reminder, we will have a raffle, and we're going to have a special coupon code coming up here, so make sure you stay tuned. You do need to be present in order to win the raffle. But we've got a shorter question. Sometimes a short doesn't mean easier. So keep that in mind as we read the lead in. Which of the following adverse effects is the most concerning reason for avoiding hydralazine in this patient? Okay, so thinking about particular med, thinking about adverse effects. Let's go ahead and read the vignette. A 70-year-old man comes to the physician because of worsening shortness of breath and ankle edema. He has a history of refractory hypertension, two-vessel coronary artery disease, and congestive heart failure treated with multiple medications. As an alternative drug for heart failure, his physician considers adding hydralazine but decides against it because of the drug's adverse effects. So, which of the following adverse effects is the most concerning reason for avoiding hydralazine in this patient? Think about it. Maybe you already have one in mind. And with that, I'm going to pass it over to Abraham.
All right. So I like this question because it's kind of non-conventional, right? So you're typically used to what's the cause, what's the diagnosis, what are you going to expect, how are you going to treat this? This is why do you not want to give a drug, right? This is a question we have to answer when we're seeing patients, and patients come in asking for certain medications. You have to think about what is the side effects of these drugs, and in every patient is different. So you have to personalize this to the patient. So this is a good clinical question and well-written question. So I want you guys to think about this one as we go through and highlight some of the keywords of this. So we have, again, the lead in. Most concerning reason for avoiding hydralazine, okay? 70-year-old man has shortness of breath, ankle edema, okay. Refractory hypertension, two-vessel coronary artery disease, and congestive heart failure treated with multiple medications. So, pretty sick guy, a lot of cardiac issues. Now, in addition to whatever he's taking, an alternative drug for heart failure is being considered. And hydralazine is the drug they're talking about, right? You have to know what hydralazine is, how hydralazine works, what their associated side effects are. And it's important to think about all of this, right? And why would the physician decide against using hydralazine in this patient in particular? So think about that. Process is going on. It's a small, short step, but it's high yield, and you want to think about why you don't want to use hydralazine. Let's look at the options here, and let's kind of explain why. Option choice E, hypercalcemia. Option choice D, bradycardia. Option choice C, anuria. Option choice B, angioedema. Option choice A, angina. All high yield, all pretty concerning, but which in this patient is the most concerning reason why we want to avoid hydralazine? Take your time, read through the vignette one more time, and try to get an understanding of why we want to avoid hydralazine in this situation.
Okay, we've launched the poll. So let's see if we can close with a nice flourish tonight. So glad to see so many of you out here. Okay, so a little over a third of you went with angina, almost 30% angioedema, and then bradycardia and anuria right there, kind of neck and neck for third place, and a few others went with hypercalcemia. Okay, well, let's hide the results and share the answer. And the answer is angina. So great job. Once again, that was a tougher question, definitely. But, the crowd really stepped up here. But still means, about 2/3 of you missed that one. So it's important that we spend a little bit of time to make sure that we fully understand it. So Abraham is going to help us get this one in shape.
All right, great job, guys. That was a tough one, and totally fine if you guys missed it, but this is a great learning opportunity. Learning about drugs and their side effects are very high yield, and it's something that you're going to have to know from step one all the way to residency and beyond. So make sure you guys pay attention for this one and understand what's going on. Okay, so the correct answer in this one is angina. Why is that the situation? We have this old guy coming in with, he's got shortness of breath and ankle edema. That by itself, not great for us to think about, but refractory hypertension and coronary artery disease and congestive heart failure multi-medication. So he's got a pretty weak heart. We want to be careful when we give certain drugs in patients with coronary artery disease, okay? Because what is coronary disease, right? The idea is that the supply and the demand isn't matched. There isn't enough supply for the demand of the heart. The pipes that are feeding the heart are clogged up, and that's what coronary artery disease is. There's limited coronary artery flow. And what do we know about hydralazine? How does hydralazine work? You got to think about this in a very basic science understanding way. Hydralazine is an arterial vasodilator. So it's great to treat heart failure, it's great to treat refractory hypertension, but in anybody with CAD, you do not want to give hydralazine. Hydralazine, it works fast, you control the blood pressure, great, but think of what's happening, right? So if I'm causing sudden vasodilation of my arteries, my body's going to have a reflex to it. The body's going to be like, oh, I'm vasodilating my arteries, that my blood pressure is going to go down. How am I going to compensate for that? It's not thinking about, oh, the fact that my blood pressure is already up to begin with. As soon as it senses that drop in blood pressure, that's when your baroreceptors in your body send a signal to the heart and saying, hey, speed up. Or more accurately, they send less of a signal of the parasympathetic to the heart, so the heart picks up speed on its own. So a reflex tachycardia is a classic symptom or side effect of hydralazine. And in somebody with CAD who's already having such demand problem with the heart, you don't want to speed up, right? That's why we put them on beta blockers. That's why we put them on other drugs to slow the heart down to reduce the demand of the heart. So when I give hydralazine, sure, I'm going to treat the hypertension. Sure, it may help with the heart failure because by reducing afterload, but it's going to cause reflex tachycardia, which can then cause pain. And we don't want to be triggering chest pain just to treat hypertension. So that's why that's the most concerning thing we don't want to be watching for. It can also cause peripheral edema. And the classic one that they do like to ask is drug-induced lupus. Hydralazine is one of the few drugs that causes drug-induced lupus. And that's that antihistone antibody. So it's a deep cut there, if you guys know that. But high yield. Other things, angioedema was a good second option that you guys picked. I think more about the ACE inhibitors and the lisinopril and these other drugs there. ARBs can also cause angioedema. Hydralazine by itself, not very classic to cause angioedema. Bradycardia, also good thought, but that's also beta blockers, calcium channel blockers. You're going to get reflex tachycardia, not bradycardia. Anuria, again, think more about my ACE inhibitors in somebody with renal artery stenosis or something that's an anticholinergic side effect, not really hydralazine in this situation. And then hypercalcemia, that's going to be my thiazides, if anything, that would cause hypercalcemia. Not typical in this situation. So in this situation, most important thing is if I see CAD, don't reach for hydralazine. Hydralazine works well in hypertension, works well in heart failure, but if I have coronary artery disease, you don't want to stress the heart more by making it pump faster. But great job, guys. This is a high yield topic to understand, and knowing the side effects of drugs and knowing which cardiac med to pick out of the bunch that you have to pick from is important. But great job.
Nice work, everybody. Again, 4 tough questions tonight, and you guys really stepped up. And more importantly, I think there's just a lot of pearls and nuggets that Abraham was able to leave us. So really thankful for all of his expertise. We do have the test from tonight. So if you want to check out those questions, you can do that by copying the link there.